Okay, ma'am.
Yes.
Shall I start, ma'am?
Yes.
The annotation.
Ma'am, live starting.
Yes.
Okay. Good evening, everyone. A warm welcome to day 8 of the webinar series on psychological disorders, triggers to treatment, organized by Team Manojagrithi under the valuable guidance of Dr. Geetha Challa, ma'am. This enriching series, which commenced on July 23rd, has brought us insightful sessions on a wide range of psychological disorders. Hope most of you have been attending this series and hope you are enjoying this series. As of today, we have covered 7 days on various disorders. Day 1, we had covered overview of psychological disorders. Day 2, we have covered generalized anxiety disorder. Day 3, postmortem disorder, depression, and premenstrual dysphoric disorder. Day 4, childhood disorders. Day 5, phobias. Day 6, schizophrenia. And yesterday, day 7, we had a powerful session on major depressive disorder and bipolar disorder. If anyone missed out or wants to watch the sessions again, they are available on YouTube. Links are provided in our webinar WhatsApp group. You can access it from there. Today, day 8 of our webinar series and we are going to explore an equally significant and often misunderstood condition, obsessive compulsive disorder, commonly known as OCD. I am Pratyusha Priyadarshini, counselor at Sudisha, and I will be co-presenting today's session along with my colleague, Dr. Sudhamshu Lohit, physiotherapist and enthusiastic counselor at Sudisha. I have always been deeply fascinated by the working of human minds. My passion for psychology led me to pursue counseling, and it brings me immense joy to be here with you today, sharing knowledge and insights into this complex disorder, OCD. Let's begin our session and delve into understanding OCD, its symptoms, causes, diagnosis, treatment approaches, and real-life experiences. Before jumping into the session, I would like to mention about Manojagrithi here. Manojagrithi, established by Dr. Geetha Challa in 2012, is a non-profit organization with a vision to create mental health awareness and preventing mental health issues, contributing to a healthy nation with strong values. Manojagrithi has three core areas: mental health awareness, capacity building, counseling, and guidance. I take the privilege of introducing our beloved Dr. Geetha Challa, ma'am, an eminent counseling psychologist. Dr. Geetha Challa is a child and adolescent psychologist, the founder and director of Manojagrithi and Sudisha Counseling Center. Dr. Geetha Challa, a multifaceted personality, has played a vital role in empowering people of all ages from different sectors. As a psychologist, personality development trainer, student counselor, academic skill trainer, social worker, early childhood education specialist, whatnot. She is playing versatile roles and has been rendering exceptional services to the society. I also take immense pleasure in introducing our Sahaya coordinator, our beloved Srimati B. Vijayalakshmi Garu, who brings both experience and heart to her role. She holds degrees in human development, rural home science, and clinical psychology. Currently, she serves as a trainer, content developer, and coordinator at Manojagrithi. Before we begin today's session, let's take a moment to center ourselves with a few rounds of conscious breathing. Hope you are all ready with a glass of water or water bottle. Keep it near you. Breathing is something we often take for granted, yet it is one of the most powerful tools to calm the mind and bring our awareness into the present moment. Let us all do conscious breathing. I will be your guiding voice. Just follow my instructions. Sit in a comfortable, upright posture with your back supported. Rest your hands gently on your lap, on your knees or on your knees. Relax your shoulders and neck. Sit in a relaxed position. Now, gently close your eyes. If you are comfortable, attention to your breath. Inhale through your nostrils and exhale gently. Let's do it again. Inhale and exhale. Continue breathing at your own pace, observing thoughts may come and go. You don't need to judge or control them. Just notice them as they are and gently bring your focus back to your breath. As you inhale, observe the expansion of the chest, and as you exhale, observe the lowering of the Let us do it two times. Inhale, exhale, calmness. Exhale all your tension. Just relax. As you breathe, allow yourself to settle. Just being here at this moment. Keep your eyes closed. Now, let's move to a called 10-5-10 breathing technique. Take a moment to become still.
Sudisha, can you breathe us now?
Take a moment
Bit louder.
to let your breath be natural and unforced. Begin begin to settle into the rhythm of breathing. Now begin 10-5-10 breathing technique. You will inhale for a count of 10, hold your breath for a count of 5, exhale for a count of 10. Take it at your own pace. Only go as far as comfortable. Let's begin. I will give a count for you. Inhale 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Hold 1, 2, 5. Exhale 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Let's do 2 more rounds. Inhale 1, 2, 3, 4, 5, 7, 8, 9, 10. Hold your breath 1, 2, 3, 4, 5. Exhale 1, 2, 5, 6, 7, 8, 9, 10. Let's just do 1 more round. Inhale 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Hold 1, 2, 3, 4, 5. Exhale 1, 2, 5, 7, 8, 9, 10. Now allow your breath to return to its natural, comfortable rhythm. Come to your normal breathing. Keep your eyes closed. Notice how your body feels calm, still, and grounded. Take a moment to simply notice, breathing softly and naturally. Keep your eyes closed. Now, to deepen our sense of presence and awareness, we will do 5, 4, 3, 2, 1 grounding technique. We will connect with the present moment through our 5 senses, one at a time, mind and non-judgmental. All of you, please keep a glass of water or water bottle with you. Let us start. First, sense of hearing. Gently tune into the surroundings. Keep your eyes closed. Try to notice 5 different sounds you can hear. They might be loud or soft, near or far. Just observe them one by one. Don't judge any sound. Just observe. Now, shift your attention to a sense of touch. Take your right hand and explore 4 different textures around you. Perhaps fabric of your clothes, chair you are sitting on, your hand, or your skin. Touch 4 things. Notice how each texture feels rough, warm, whatever it may be. Just feel without judging. Next, bring your awareness to your sense of smell. Try to identify 3 different scents, smells around you. Maybe the smell of your skin, the smell of your clothes, the air, or any nearby object. Be curious. Don't judge. Just observe whatever comes.
Pratyusha, can you stop the music?
Music object. Okay. Now, gently rub your palms together to create warmth. Place your warm palms softly over your eyes. Take a deep breath in and out. When you are ready, slowly open your eyes. Look around and notice 2 things you can see. Observe their color, shape, and texture as if you are seeing them for the first time. Now, Let's bring our awareness to the sense of taste. Now, slowly pick up your glass beside you or water bottle. Observe it carefully. Notice the shape of the glass or bottle. Just observe. Bring your awareness to the water inside. This is not just any liquid. This is life-giving water, the very source of your survival, health, and well-being. Gently lift the glass and bring it close to your lips. But don't drink it yet. Now, take a small sip. Let the water rest in your mouth for a moment. Feel the texture, the temperature. Slowly swallow. Feel the water moving down your throat. Notice the sensations, how your body receives it. Take a deep breath in and slowly exhale. Bring your attention back to your body. When you are ready, return to the present moment, grounded, calm, and aware. These simple breathing and grounding techniques are not just ways to begin a session, they are tools we can carry into your daily life, especially when dealing with overwhelming thoughts or emotions. With that sense of calmness and awareness, let's now begin our session on obsessive compulsive disorder or OCD, a condition that is often misunderstood yet deeply impacts the lives of many. Before we dive deep into understanding OCD, let me ask you something interesting. How many of you have watched the Telugu movie Mahanubhavudu starring Sharvanand? You can type me in the chat box if you have seen the movie. Do you remember his character? He was obsessed with cleanliness, washing hands multiple times, getting anxious when someone touches his things. Does that ring a bell? Now let me ask you, do you think the character in the movie was just being neat and tidy, or did it look like something more intense? Did his thoughts and behavior start interfering with his daily life or relationships in the film? If you think yes, type yes in the chat box. Thank you for your responses. Do you know anyone who is extremely particular about cleanliness? Have you come across anyone in your life? We somewhere or the other come across these types of characters in our daily life, isn't it? While the movie presented it, it actually touches on a serious mental health condition called obsessive compulsive disorder. This is a difference we need to understand between a personality trait and a disorder. OCD is not just about being clean or organized. It involves intrusive thoughts, which are called obsessions, and repetitive behaviors called compulsions that the person feels forced to perform even when they know it is irrational. So while Mahanubhavudu made us laugh, in real life, people with OCD often struggle silently. Today, we will learn how to identify, understand, and support these dealing with the OCD. Let's start. According to the Diagnostic and Statistic Manual of Mental Disorders, 5th edition DSM-5, published by APA, American Psychiatric Association, the category of obsessive compulsive and related disorders includes a group of conditions that share features such as intrusive thoughts, repetitive behaviors, and difficulty resisting urges. These disorders include obsessive compulsive disorder, OCD, body dysmorphic disorder, hoarding disorder, hair pulling disorder, excoriation, that is a skin picking disorder, substance or medication induced obsessive compulsive and related disorder. Each of these disorders has its own specific diagnostic criteria, but shares common underlying features related to obsessive thoughts or compulsive behaviors. Disorders listed here, obsessive compulsive disorder, OCD, is the most well-known and widely studied. Let's now move deeper into understanding of obsessive compulsive disorder, OCD. Now let's take a quick look at how common OCD really is both globally and in India. Global prevalence, obsessive compulsive disorder affects about 2 to 3% of the world population. And as per the DSM-5, the lifetime prevalence is approximately 2.3%. The onset usually occurs in between 8 to 12 years or during early adulthood. In India, studies have shown a prevalence ranging from 0.6% to 3.3%. NMHS, National Mental Health Survey 2015-16, reported a prevalence of about 0.8% among adults. It is important to note that OCD is often underdiagnosed, especially due to stigma and lack of awareness. Also, urban areas tend to report slightly higher rates, possibly due to better awareness and reporting. These numbers remind us that OCD is not rare. It's more common than many of us realize, which makes it all the more important to understand it, identify it, and talk about it openly. Now, we'll go further. What is OCD, Obsessive Compulsive Disorder? There is a public misconception that OCD is just minor personality quirk and that everyone is a little bit OCD. But in reality, OCD is a serious mental health disorder that affects people of all ages and walks of life and occurs when a person gets caught in a cycle of obsessions and compulsions. These symptoms cause significant distress and interfere with a person's daily functioning, including work, relationships, and social activities. Let's understand OCD more deeply through a couple of case studies. The first case is Priya's nightly ritual. Let me introduce you to Priya, a 28-year-old female marketing executive based in Mumbai. She reports having intrusive thoughts about her house being burgled at night. To ease her anxiety, she feels compelled to check the locks on all doors, windows, and cupboards, not once, but 10 to 15 times before she can sleep. This checking ritual makes her late to work regularly, causes disturbed sleep, and she often wakes up in the middle of the night to recheck the doors. It has created strain in her relationship also, as her partner finds it hard to understand her behavior. What might be her primary obsession? Can anyone tell? You can answer in the chat box. What might be her compulsion? What might be her primary obsession? And what might be her compulsion? Sudamshu, are you able to
Yes.
see the chat box?
Yes.
Can you read it out for me?
Fear and insecurity, repetitive thoughts, safety, loneliness.
Yes. Thank you. Thank you for your responses. So what's happening here? Her primary obsession is the fear of her home being broken into. Her primary compulsion is the repeated checking of locks to reduce that anxiety. This cycle of obsession, anxiety, compulsion, and temporary relief is a classic in OCD. Let us move on to the case study 2. Peter's fear of germs and dirt. Next, look at Peter, a 22-year-old male working as a software engineer in Bangalore. Peter experiences persistent intrusive thoughts about contamination. To manage these thoughts, he washes his hands repeatedly, spends over 3 hours daily cleaning, 3 hours, avoids touching doorknobs, public surfaces, and even pets, refuses to shake hands or hug people, And he avoids public restrooms and crowded places. Always experiences severe anxiety when unable to wash or clean. His compulsive behaviors have started affecting his work and relationships also. This is a common presentation of contamination OCD. So Peter resembles Sharvanand in Mahanubhavudu movie, isn't it? Same characters, same symptoms. The obsession here is the fear of germs and contamination. The compulsion is repeated hand washing and cleaning. So these are all the two cases which helps us to understand the obsessions and compulsions of OCD. Have you ever encountered someone with similar habits that might be mistaken as just being neat? When does it cross the line into OCD? We will be knowing in the later slides. And let us understand about obsessions. This is the first core component of OCD. Obsessions are not just ordinary worries or thoughts. They are recurrent, persistent, and often intrusive thoughts, urges, or mental images that come into a person's mind even when they don't want them. For example, someone might have unwanted thought that they have harmed someone. Even though they haven't, this thought keeps coming back again and again and creates guilt and anxiety, even though they logically know it is not the true. Such obsessions can become so overwhelming and that they interfere with work relationship and even basic social activities. Let us go through some common obsessions in OCD. Contamination of obsessions, we have just gone through. Fear of coming into contact with perceived contamination substances like body fluids, germs, environmental contaminants, household chemicals, dirt. Violent obsessions, fear of acting on an impulse to harm oneself or harm to others. Excessive concern with violent or horrific images in one's mind. These are all violent obsessions. Responsibility obsessions, fear of being responsible for something terrible happening. Fear of harming others because of not being careful enough. Some more common obsessions in OCD. Perfectionism related obsessions. Excessive concern about evenness or exactness. And excessive concern with the need to know or remember. Fear of losing or forgetting important information when throwing something out. Excessive concern with performing tasks perfectly or correctly. Fear of making mistakes. And next one is sexual obsessions. This is also one of the common obsessions. Unwanted thoughts or mental images related to sex, including fears of acting on sex-related impulse, fears of sexually harming children, relatives, or others, fears of performing aggressive sexual behaviors towards others. And religious moral obsessions, scrupulosity. This is fear of offending God and concern about blasphemy, excessive concern with the right or wrong, or excessive concern of morality. Now that we have understood obsessions, let's talk about The second part of OCD, compulsions. Compulsions are repetitive behaviors or mental acts that a person feels driven into perform in response to an obsession. These actions are meant to reduce the anxiety caused by the obsession or to prevent something bad from happening, even if the person knows deep down that behavior doesn't really help. For example, if someone has an obsession about germs, they may feel the need to wash their hands 20 to 30 times a day. It's a quite big number. 20 to 30 times a day, not because they enjoy it, but because it feels necessary to relieve the anxiety they suffer. Over time, compulsions become exhausting and take a toll on the person's well-being and the activities they value. And let us move on to the common compulsions in OCD. Washing and cleaning obsessions. These are all compulsive actions, repeated actions. Washing hands excessively, excessive showering, bathing, toothbrushing, grooming, cleaning household items and other objects. Doing other things to prevent or remove contact with contaminants. Checking obsessions. So checking that you did not harm others, you did not harm yourself, nothing terrible happened, you did not make a mistake. So those are the checking obsessions. Repeating obsessions. Routine activities going in or outdoors. Body movements, for example, tapping, touching, and blinking. So they will repeat those things. Activities in multiples, doing a task 3 times because 3 is a good or right or safe number. So some more common compulsions here. Mental compulsions. Mental review of events to prevent harm. Praying to prevent harm. Counting while performing a task to end on a good, right, or safe number. Cancelling or undoing. Other compulsions, putting things in order or arranging things until it feels right. Telling, asking, or confessing to get reassurance repeatedly. Avoiding situations that might trigger your obsessions. And now let's understand how these two elements, obsessions and compulsions, interact in what we call the OCD cycle, a repeating loop that manifests and that maintains the disorder. The cycle typically follows 4 stages: obsession, anxiety, compulsions, and temporary relief. Obsessions are, as we already seen, unwanted, intrusive thoughts or fears. Anxiety, these obsessions cause intense discomfort or distress. Compulsions, to reduce the anxiety, the person engages in repetitive behaviors or mental acts, compulsive actions. Temporary relief. The compulsion offers short-term relief, but the obsession soon returns, restarting the cycle again. This cycle can be exhausting and time-consuming, trapping individuals in a loop that's hard to break without help. This OCD can be divided into 3 patterns. Only obsessions. There will be only obsessions for some people. There will be only compulsions for some people. There will be both obsessions and compulsions. So only obsessions, they have intrusive thoughts without any visible rituals or repetitive actions, compulsive actions, only intrusive thoughts they are having. For example, repeating thoughts of harm, doubt, or guilt. And some people are having only compulsions. So only repetitive actions, there will not be any trigger for the repetitive actions. For example, tapping, touching, or counting rituals. Thoughts and rituals are both obsessions and compulsions. There will be intrusive thoughts as well as repetitive behaviors and compulsive actions. For example, fear of contamination. For fear of contamination, it's an intrusive thought, and excessive hand washing is a repeated behavior. OCD doesn't look the same for everyone. It can manifest in various forms depending on the theme of obsessions and the compulsions that follow. Let's look at some of the most common types of OCD. We already covered these types in previous slides. Let's have a brief recap of those. Contamination OCD, that's fear of germs, dirt, illness. This leads to excessive washing, cleaning, avoiding public places. Relationship OCD, obsessions about the quality or rightness of a relationship. Individuals may constantly question their feelings, their partner's behavior, or seek reassurance. Superstitious OCD involves irrational fears that something bad will happen unless specific rituals. Checking OCD involves repeatedly checking locks, appliances. It's driven by fear of accidents, errors, or irresponsibility. Harm OCD, fear of unintentionally causing harm to oneself or others. Thoughts may involve violence or accidents even if the person would never act on them. Perfectionism OCD, an overwhelming need for symmetry, exactness, or things to be just right. It often leads to mental or physical rituals to achieve a sense of balance. Religious or moral OCD, scrupulosity, involves obsessive guilt, fear of sin, moral failure. People may excessively pray, seek forgiveness, or avoid situations that could be morally wrong. Sexual orientation OCD involves intrusive doubts or fears about one's sexual orientation, even if there is no actual desire or reason for questioning it. This can be deeply distressing. Each type may vary in intensity and overlap with others, but the core pattern of obsessions, anxiety, and compulsions remains the same. Let's go through a few quick questions for better understanding obsessions and compulsions. Which of the following is not an example of a common obsession in obsessive compulsive disorder? A, fear of contamination. B, fear of causing harm or making mistakes. Fear of heights. D, need for symmetry or exactness. I request audience, please type your answer in the chat box. Sudamshu, you please go through the chat box and tell me answer.
Yes, please.
I'm not able to.
Fear of heights.
Yes, absolutely true. Fear of heights is a kind of phobia. It's not a OCD symptom. Thank you for your responses. And we'll move on to the next question. This is fear of heights. And what is the key characteristic of compulsions in obsessive compulsive disorder? regarding the connection to obsessions. What is the connection between compulsions and obsessions? The four options are here. A is compulsions always mirror the content of the obsessions. B, compulsions are only performed if the obsession is rational. C, compulsions are completely unrelated to obsessions. D, compulsions do not have to be directly connected to the obsession or feared event. Please type your answer in a chat box.
Yes. Answer is A.
Yay. Okay. Any more responses?
Some
B, C, D. You have given C and D also.
yes. Some have given D, some have given C and D.
Okay. Answer is D. Compulsions do not have to be directly connected to the obsessions or feared event. There must not be a direct connection to the obsession. That is the right answer. And we will move on to the next question. What are obsessions in obsessive compulsive disorder? A, efforts to avoid unwanted thoughts and images. B, repetitive tasks performed in response to obsessions. C, tasks that are realistically connected to the distressing thoughts. D, unwanted intrusive recurrent thoughts, images, or are just causing anxiety and distress. Please use chat box to respond. Type your answer in your chat box.
Some have given B, some have given D.
Okay. The answer is unwanted, intrusive, recurrent thoughts or obsessions. And the last question, what type of compulsions are examples of mental compulsions in obsessive compulsive disorder? A, avoiding certain situations, seeking reassurance. B, arranging items in a specific order, repeating actions multiple times. C, cleaning or hand washing, organizing, checking. D, repeating words silently or praying, counting, ruminating. What are the mental compulsions? Can you please type in the chat box your answer?
Mostly are answering it as A.
A. Okay. The right answer is repeating words silently or praying, counting, ruminating. So these are the mental compulsions. There will not be any intrusive thoughts. With this, we have now understood obsessions and compulsions in detail. I now hand it over to Sudhamshu to take it forward. Sudhamshu, over to you, Sudhamshu. Please
Okay.
take it forward.
Good evening, everyone. Thank you, Pratisha ji, for enlightening us with the introduction to OCD. Now, we will be going deep into OCD behavior. When does a behavior become a disorder? We have seen that in OCD, a behavior is transformed into a disorder. So, when it happens and what is the process in it? Let us go through it. The World Health Organization defines a mental disorder as a significant disturbance in an individual's cognition, emotion, regulation, or behavior that reflects a dysfunction in psychological, biological, or developmental processes underlying mental functioning. Now, any behavior before becoming into a disorder, there is a pattern which is it goes through firstly significant distress. The behaviors or thoughts cause significant personal distress, discomfort, or suffering to the individual, which lead to functional impairment, that is, social, occupational, or other areas which are important get impaired. Then this leads to persistence and increase in the duration of this functional impairment and distress. So the symptoms are persistent and endure for a considerable period, often exceeding arbitrary time frames set by diagnostic criteria. For example, arranging books neatly is a preference for many people, but it becomes indicative of OCD only if it causes extreme distress when not done or takes up an excessive amount of time, impairing daily life. According to DSM-5 diagnostic criteria, there are 4 criteria for OCD. The first criteria A, there is presence of obsessions, compulsions, or both. This is the foundational criteria requiring the existence of either intrusive thoughts or repetitive behaviors or both. Criteria B, it's a time consuming or clinically significant distress or impairment. The obsessions or compulsions are time consuming, that is, they take more than 1 hour per day or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Criteria C and D is of the exclusion of other causes. That is, the obsessive compulsive symptoms are not attributable to the physiological effects of a substance abuse or a drug abuse or a medication abuse or any other medical condition, nor are they better explained by the symptoms of another mental disorder. This way, DSM-5 diagnostic criteria categorizes OCD into 4 criteria. Now, let us just discuss about some myths and facts related to OCD. Everyone has a little bit of OCD. Is this a myth or a fact? It is a myth or fact. It is a fact. Is OCD just anxiety? Please give your responses in chat box. Or is OCD just anxiety? Thank you for your responses. Everyone does have a little bit of OCD. But fact is, while many people have routines or preferences, OCD is a clinical condition that causes distress and impairments. Next, coming to whether OCD is just anxiety. No, OCD is not just anxiety, it is a myth. Fact is, while anxiety is a prominent feature, OCD is a distinct disorder in the DSM-5, separate from anxiety disorders. Anxiety is a symptom of OCD. Its core features are obsessions and compulsions, which drive the anxiety rather than general worry. So it's crucial to differentiate between normal habits and pathological compulsions that significantly disrupt life. Then going on with myths and facts, is being neat is OCD? No, the fact is, while some individuals with OCD may have contamination fears or symmetry obsessions leading to excessive tidiness, neatness itself is not a disorder. Can people with OCD just stop their thoughts and behaviors? No, OCD is a mental disorder and people cannot simply stop without help or treatment. May, Myth: OCD is caused by poor parenting or stress. No, fact is OCD has biological, genetic, and environmental causes, not just stress or upbringing. Myth: OCD is rare and doesn't affect many people. No, the fact is OCD affects 2 to 3% of the global population, cutting across cultures and age groups. Myth: is medication the only way to treat OCD? No, the fact is medication is not the only way to treat OCD. CBT with exposure and response prevention is often more effective than meds alone. You can combine this treatment with meds for a better outcome. Hope now you're clear with the facts related to OCD. Now,
Sudhamshu,
let us
go on.
let us delve into the causes of OCD. OCD arises from a complex interplay of various factors encompassing biological, psychological, and environmental influences. The biological factors which can cause OCD are genetic predispositions, brain structure abnormalities like orbitofrontal cortex abnormalities, neurotransmitter imbalances like serotonin increase susceptibility causes OCD. Then psychological factors can be cognitive distortions such as overestimating threats and needing certainty, learned behaviors through conditioning. Environmental factors can also lead to OCD, like a history of trauma, abuse, or significant stress. Childhood infections like pandas can trigger or exacerbate OCD symptoms. Understanding these multifaceted causes is vital for effective prevention and treatment strategies. Now, let us go deep into research insights on OCD. A lot of research is going on into OCD management and treatment. Now, neurology, in neurobiology also research is going on where it is being observed that hyperactivity in CST brain circuit can also treat OCD. Neurotransmitter imbalance management can also treat OCD. Genetics. First, it has been observed that first degree relatives have more 2 to 4 times higher risk in developing OCD. Moderate heritability has been observed in twin studies. Now, what is the treatment research outcomes? CBT with ERP, cognitive behavioral therapy with exposure response prevention is a gold standard in psychological management of OCDs, coupled with medical management where SSRIs are effective. And a lot of new approaches are being developed into this treatment modalities like glutamate modulators, TMS, which is transcutaneous magnetic stimulation of the brain, and genome wide studies are being looked at in the research avenues. Now, let us just go through what are the common triggers of OCD. Triggers are what? Triggers are situations, thoughts, or objects that provoke obsessive thoughts and the urge to perform compulsions. These vary between individuals but often include contamination triggers like public restrooms, hospitals, garbage, doorknobs, shaking hands, or touching shared items. Safety and checking triggers like fear of leaving the gas on or doors unlocked, which was discussed in the story of Priya. Reading distressing news about fires, accidents, or break ins. Order or symmetry triggers. Seeing items out of alignment, asymmetrical or disorganized environments. And furthermore, harm related triggers like holding sharp objects, taboo or intrusive thought triggers. Some religious symbols or texts can induce OCD symptoms. Watching certain types of media like sexual or violent content can also trigger OCD symptoms. Social triggers, being judged or misunderstood, saying or hearing specific words or phrases can also trigger OCD symptoms. Now, let us just see what is the difference between OCD and OCPD. OCD primarily involves anxiety and distress caused by intrusive thoughts, whereas OCPD involves a need for control. OCPD primarily involves a need for control and order. OCD involves unwanted obsessions and compulsions. OCPD is a personality pattern. OCD symptoms fluctuate in response to anxiety, whereas in OCPD, symptoms don't usually fluctuate, they stay put. Then in OCD, typically starts in childhood. OCPD typically starts in adolescence or young adulthood. In OCD, the person perceives their thoughts and behaviors as excessive, whereas in OCPD, the person doesn't perceive their behaviors as problematic. So, this differentiates OCD from OCPD. Now, when to consult a professional for OCD management? You need to consult a professional in order to control intrusive thoughts and be happy when you have obsessive thoughts or compulsive behaviors that interfere with daily life. If you are spending more than 1 hour per day on obsessions or compulsions, avoidance of situations due to fear or anxiety, if you are having feelings of distress, shame, or exhaustion from repetitive thoughts or actions, if you are not finding any relief despite trying to resist or control the behavior, if the symptoms that are affecting relationships, work, or academics, in all these situations, it is better for you to consult a professional. We advise you not to undergo self-assessment for OCD and please seek professional help to better understand your problem and get effective treatment. So, whom to consult in OCD? You can consult a psychiatrist, a clinical psychologist, a counselor or therapist, a family physician, or a pediatrician. Now, what role do these people play in OCD management? A psychiatrist diagnoses OCD, he prescribes medications. Clinical psychologist provides CBT, exposure and response prevention therapy. Is counselor or therapist. Counselor or therapist offers supportive counseling, helps manage stress and triggers. Family physician and general practitioner. He's the first point of contact and he refers to specialists. Pediatrician. Pediatricians are the best sources for identifying OCD in children and adolescents, wherein you can identify them when they are in their buds and can effectively be managed into beautiful and capable adults. There are some assessment tools for OCD, which are Yale Brown Obsessive Compulsive Scale, Children's Yale Brown OCD Scale, Obsessive Compulsive Inventory Revised Scale, and Dimensional Obsessive Compulsive Scale. Mental status examination. The mental status examination provides a structured way to assess a client's mental state at a given time. For OCD, certain domains are particularly relevant, wherein appearance, behavior, thought content, and insight are of vital importance. Behavior. The person with OCD may appear anxious, restless, or fatigued due to sleep deprivation. Grooming might be meticulous or neglected, depending on specific obsessions or compulsions. Behavior. Presence of repetitive behaviors, ritualistic behavior, or compulsive acts. These behaviors might appear rigid or purposeful, yet feel senseless to the client. In thought content, dominated by obsessions. Insight, often variable. Clients typically recognize their obsessions or compulsions as irrational or excessive, but may have poor insight during acute episodes. Effective treatment options for OCD management. Pharmacological interventions wherein SSRIs, selective serotonin reuptake inhibitors, are given, and other medications. In cases of severe treatment resistant OCD, other medications may be considered, like tricyclic antidepressants. Atypical antipsychotics may be used as an augmentation strategy. But still, we advise you to seek professional help, and medication is only to be taken on prescription by qualified professionals. There are various non-pharmacological therapies which can help you in management of OCD. They are cognitive behavioral therapy, exposure and response prevention therapy, group therapy, stress fit well-being toolkit, in which exposure and response therapy is considered the gold standard. There are some other evidence-based therapies for OCDs, like acceptance and commitment therapy, which helps clients develop psychological flexibility by teaching them to accept unwanted thoughts and feelings without trying to change them, while committing to actions aligned with their values. Family therapy, particularly crucial for children and adolescents with OCD. It educates family members about the disorder, helps them reduce accommodating behaviors, and improves communication to support recovery. And other important therapy, which is the gold standard, which we have said and again reiterating, is CBT plus ERP. CBT plus ERP breaks the link between obsession and compulsion, reducing anxiety over time. Now, I'm request Pratyusha ji to explain about ERP in detail so that it would be very knowledge sharing for people to understand what ERP is. Over to you, Pratyusha ji.
Thank you, Sudhamshu, for emphasizing myths, facts, causes, triggers, and research insights in detail. Now let's move ahead with more focus on ERP, exposure and response prevention therapy. This is very important therapy. One of the effective and evidence-based treatments for OCD is ERP, which stands for exposure and response prevention therapy. It is a structured behavioral approach that helps individuals face their fears and break the OCD cycle. Let's look at the 4 key stages involved in ERP. There are 4 stages. First one is gradual exposure. This stage involves helping the person face the situations, objects, or thoughts they fear, but in a gradual and controlled manner. For example, someone afraid of contamination may first touch a clean doorknob, then gradually touch a public one, all without immediately washing their hands. Second stage is response prevention. Resist compulsive behaviors. Learn that feared outcomes don't occur. This helps to break the link between obsessions and compulsions. Third one is tolerance building. Stay with the anxiety. Now the person learns to sit with the anxiety without reacting to it. Anxiety reduces naturally over time. It becomes habituation. This builds emotional strength and increases the person's confidence in handling distress. Fourth stage, cognitive restructuring. The therapist helps the person identify irrational thoughts and replace them with more realistic, balanced thoughts. Especially useful when the obsessions are tied to deep-rooted beliefs. For instance, instead of, if I don't check the door 10 times, something bad will happen. This will be the thought, intrusive thought. They learn to think, I have locked it once properly and that's enough. So restructuring, cognitive restructuring will happen in this stage. And ERP, exposure and response prevention theory, is a key component of a CBT, cognitive behavioral therapy. Is a gold standard evidence-based treatment for OCD. It helps individuals face their fears, break the cycle of compulsions, and manage anxiety effectively. Now, let's talk about coping strategies, a vital part of managing OCD. In the context of OCD, they help individuals manage anxiety, reduce the intensity of obsessions, and resist the urge to perform compulsions. Observe your thoughts like a detective. Challenge your worries. Put your worries on trial. Distract your mind. Find your favorite escape. Coping sentences are positive, grounding statements that individuals can repeat to themselves during moments of anxiety or intrusive thoughts. Let's look at some coping sentences that are helpful to manage OCD symptoms. A thought is just a thought. It does not define me. I choose to observe this thought without judgment. It's okay to feel the discomfort. It will pass. I deserve peace and patience. This urge will fade. I don't need to obey it. I can allow this thought to pass without reacting to it. Every time I delay a compulsion, I get stronger. I have handled this before I can do it again. With that, we come to the end of today's session on obsessive compulsive disorder. We have explored what OCD really is, how it manifests through obsessions and compulsions, that the cycle it creates, different types, assessment tools, and effective coping strategies also. Remember, OCD is not a personality trait or a quirk. It's a treatable mental health condition, and with the right support and interventions, individuals can lead fulfilling lives. Now, we would love to hear from you. If you have any questions, thoughts, or reflections, please feel free to share. This is an open space for discussion. Over to the audience. We are happy to answer your questions. I'm now pleased to hand over to the session to our esteemed guide and mentor, Dr. Geetha Challa, ma'am, who will take us forward with the Q&A segment. Ma'am,
Right.
are you there?
Yes,
Over,
ma'am. Yes,
over
ma'am.
to you, ma'am. Thank you.
so much. Thank you so much, Pratyusha and
Thank you,
Sudhamshu.
ma'am.
Congratulations, both of you. It was a wonderful, detailed, insightful webinar with a lot of details, and the coping sentences are really wonderful. They can actually make a difference in the client with OCD. So powerful sentences, so powerful coping sentences.
Thank you so
And
much.
your description was wonderful. So I was sitting and really listening to both of you. Beautifully done. Once
I
again,
request audience
congratulations.
to
And
please
yes,
utilize this.
any questions they can ask
Any-
now. We are ready for questions.
Sudhamshu, please read the
So
questions.
thank you so
I'm
much.
not able to.
Yeah, sure.
Someone is appreciating you.
Yeah, so they have thanked you.
Yes, yes. Good, good.
Full form of OPCD. It's not OPCD, it is OCPD.
Obsessive compulsive personality disorder. It is not OCD, but it is a type of personality problem where the person will be very, very, over cautious about discipline, organizing things, punctuality, time management. And it is not OCD, it is OCPD. It's a personality. Yeah. Any other questions? But otherwise, it was a wonderful session, but still we'll wait for questions. Yeah. Yes, Radha, it was wonderful session. Thank you so much. And you can unmute if you want to ask something or comment.
Any questions, Sudhamshu?
Or any comment on the
Any
webinar.
questions
We'd love to
anybody
listen
wants
from
to
you.
ask?
So the webinar is very detailed, I think.
That's why
So you have given a lot of information. Good job. Can we give replacing thought to unwanted thought? No, Mayuri, that's a basic difference. I thought I actually asked Pratish also or Ramshu also to focus more on. The negative thoughts will be replaced. Negative thoughts, you can stop sharing. Negative thoughts can be given a restructured thought, but obsessions are recurrent negative thoughts which are not rational. So you need not restructure them. It's just you ignore them. You don't give any value to that thought. So there is a lot of difference between dealing with a negative thought or dealing with the obsession. Both are entirely different. So first and foremost, the client or the family members who are having OCD condition, they should understand that it is not negative thinking. Very sadly, it is not negative thing. It's more of an obsession. There is no rational, there is no base. Suddenly the thought comes and it will be very, very strange. And they believe it. That's a problem. Okay. So no restructuring for this thing.
Ma'am, another question. Can a kid aged 2 or 3 years have these symptoms of OCD?
Yes. OCD is for children also. I have seen a child. Stop sharing, no, that Q&A wala slide so that it is more visible for them. Pratisha, can you stop sharing?
Okay.
It is not helping actually. Yeah, this is better. So what I was trying to tell you, children. So young children of 2 years, 3 years. I have personally seen a child who was 4 years old. 4 years old suffering with OCD, and I've seen just one more kid, a girl with 6 years. So this 6 years old child, the young girl, she used to say that um, she if the mother take her to the bathroom for bathing, she used to say that, Mama, the bucket full of water, it will be there. But she used to say, no, I think there is some urine has fell into this water. It was so strange. But then she used to believe, and sometimes she used to say, Mama, I will become mother, I will bear a daughter, and you will die. So many things like this. And it was very pathetic. The parents were suffering a lot, but then I said, they are not true, and what child is speaking also not true. Then we really worked with the girl, and she could manage it later. And one more boy who was having compulsion of keeping the slippers in order, or toys in order. Anything he see, it should be in the order. And he was very young. And one day, how the parents understood, they took him, they went to a temple, and all the slippers were there, like lying. So this boy was so irritated, so frustrated, and anxious that all the slippers should be kept in place. And parents could not stop him that day. And he wanted parents also to help to keep the slippers in order. All the in the temple, it was so messy. So then that was a point where they came and spoke to a psychologist. They came to me, but then immediately I sent them to a psychiatrist first, and then clinical psychologist, and then I was in the place. So yeah, children also suffer, and I've seen many cases. Any other question? I'm sure.
Next question is, are continuous negative thoughts also a type of OCD?
Can we give stop statements to tell our brain to stop it? Okay. What was this thing?
No, the earlier question was, are continuous negative thoughts are also a type of OCD? How can this be got over?
No. If it is overthinking, it is not OCD, it is overthinking. Only it becomes obsessive dominant or ODD. Obsessive dominance is like the thoughts will be there, only thoughts, no compulsions. But these obsessions are like very unrealistic. What you are talking about is continuous thinking is not OCD. It's more of overthinking or rumination. If you're thinking about the past, it's called rumination.
Next question is, can we give stop statements to tell our brain to stop every time we get thoughts?
No, it is not possible. If that is possible, everybody will do. No need of counselor or psychologist. No, Mayuri, it is not possible. Yeah. Any other thought? Any other question?
Another thought, ma'am, not a question. Anuradha Bansali has mentioned that it is not a fact that we teach children. Is it not the fact that we teach children at their tender age to keep the things on its place?
Definitely. So there is a slight, very fine line between organizing thing, being organized, and obsessed about organizing. So I'll tell you the difference. If things are messy, if the child want to organize, that's a very good idea. Definitely he should do. But now take this case. It is a temple. The slippers are somebody else's. But if the slippers are not kept in the order in a serial, the child was so anxious. He was not able to stop himself. That is the difference between desire to be organized or obsessed to be organized. Both are entirely different. Okay.
No further questions, ma'am.
Yeah, one question by Mayuri I just saw. We have to ignore words of children and we should not show any expression on our face. Okay.
It is just a thought she expressed, ma'am. When when you answer to the question, can we give stop
Right.
statements?
Correct. Yes. But how? But it is not continuously. You can ignore if this is happening with your child.
Can I ask a question?
Yes, ma'am.
What if the child unconsciously learns from his parents
What?
the things to keep them in the order, everything?
That's what I'm telling. See, being organized, being neat, clean, or these are all very, very important things in life, which are required also. And you should be role model for the children. There is no question about it. But it becomes OCD when it is creating an anxiety in you, or it is giving you a thought that something will go wrong if I don't do it, or God will punish me if I don't do it. Then that is OCD. It is totally different.
Okay. My daughter is 4 years old. So by sleeping in the night, she doesn't go to bed without putting the toys in the cupboard. She insists me to put the toys in the cupboard, and if I doesn't put it, she wakes up in the middle of the night and tell me to put the toys in the cupboard.
Okay. Yeah, but still it is not OCD.
Okay.
Still not OCD.
Thank you.
And you need to check other patterns, organizing patterns in her. So if she's having in other areas also, and if she's becoming very anxious if they are not in order, then maybe you can think about it.
Okay. Thank you.
Okay, I think no questions in the chat box, but still we are open. We are there and then we'll be coming up with one more webinar. Can we listen to the next webinar's details, Ratisha?
Yes, ma'am.
Please.
Thank you so much, ma'am.
Thank you so much, Andy. Thank you so much.
Thank you so much,
Patiently
ma'am.
answering all the questions and sharing your insights. Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am. Very insightful session.
I would also like to extend my heartfelt thanks to all the audience for your enthusiastic participation and engagement throughout the session. A special thanks to Team Manojagrithi and our respected mentor, Dr. Geetha Challa ma'am and Vijayalakshmi ma'am, for organizing this wonderful and insightful webinar series on psychological disorders. In this context, I would like to mention about our Sudisha Counseling Center. Sudisha Counseling Center offers a wide range of services tailored to meet the diverse needs of their clients. These services include individual counseling, couples and family counseling, child and adolescent counseling, group therapy, workshops, and training programs. And at Sudisha, we provide online, offline assessment and screenings by expert RCA certified psychologists also. If you have any concern, please feel free to reach out to Sudisha, and contact numbers and address or given in this slide. If you want to have a screenshot, you can take a screenshot also.
Before leaving, I too want to thank Geetha ma'am, Vijayalakshmi ma'am for their continuous support and motivating us in delivering such a beautiful topic, and also to all the co-participants for all the webinars and also for the attendees. Thank you. Thank you, ma'am, and everyone.
Before we conclude, I warmly invite you all to join us tomorrow for day 9 session, where we will be discussing internet addiction disorder by Rima Sen and Kavita Balamani, another important topic in our mental health journey. Thank you, one and all. Have a peaceful evening. Thank you so much. Thank you, ma'am.
Thank you all.
Thank you. Bye-bye.